Welcome, friends. This is Dr. Sharad Jaitly from New York on your favorite website, MuniMeterHealth.com, which is dedicated, as you know, to teaching human heart and its illnesses and spreading the education across the globe on the two channels which we feature on, the YouTube and the Facebook. I hope you're on either of them, perhaps on both of them, which would be good because that could be used as a backup just in case one app does not work. I once again thank you for your enthusiastic support and a tremendous interest that people have shown already by associating with MuniMeterHealth.com. So without any further ado, I'd like to delve into the subject matter, and the matter of the subject being today, what is myocarditis? Obviously, as the name suggests, especially for the students, any itis implies inflammation. Remember that. So there is an inflammation now. You could have inflammation as a result of so many things. It could be a viral etiology, for instance, or it could be protozoal, like in South America, we see Chagas disease specifically, and it could be bacterial, especially like HIV, for instance, or Mycobacterium tuberculosis has been defined in mixed infections with HIV and Mycobacterium tuberculosis. Of course, HIV is a viral etiology here, so that should go up here as well. But they invariably have Mycobacterium atypical or tuberculosis variety. One should also see trichinosis. That could be another parasite. And amongst the viral, I would say the adenoviruses, then enteroviruses, especially the Coxsackie group. Remember the Coxsackie group? It's very, very important. And other viruses. Oh, by the way, in bacteria, one should also think of Lyme disease. It's very important these days, specifically in the endemic areas like in Northeast where there's a lot of deer. So one should think about Lyme disease and causing Lyme myocarditis. They invariably end up with AV blocks and require a pacing wire to be inserted. So, and then autoimmune. Do not forget that autoimmune is also another entity where there's a self-antigen conversion because of an foreign antigen that comes in, and we do not know the etiology. There is probably a genetic predisposition, obviously, with autoimmune mechanisms. So that could result into some immune modulation, and as a result, the cells could be starting to show signs of inflammation. There would be more remodeling, and sometimes cell necrosis as well can be seen. Now, pathophysiologically, if you were to look at, obviously there are criteria, but there is the most accepted criteria is the Dallas criteria, which is Dallas, Texas, I believe. So that's the criteria where, again, it's not totally 100% proof, but the fact is that Dallas criteria is the most accepted criteria microscopically if you were to look at under a biopsy. So you need to see the inflammation, obviously, the inflammatory cells, and then you need to see the cell necrosis of the myocytes. So one, you will see inflammation, and then cell death. Both will be, a myocyte death will also be in the same section of the biopsy. That pretty much is the pathognomonic of myocarditis. So you have inflammatory component and have a cell necrotic component within the same section or same slide of the biopsy one takes. But again, this entails interventional approach, and therefore it's not very, very popular yet. Now, clinical features, if you were to look at, well, clinical features can range from simple viral syndromes, if you will, like the patient may be sick for a while and may not even notice and may not manifest to the doctor when presenting. It could be several weeks before, prior to the actual onset of heart failure or the symptoms and signs of heart failure. So symptoms and signs of heart failure will be present, obviously, namely the dyspnea. There will be chest pain, there might be palpitations because of the arrhythmias involved, there might be presyncope or syncope, patient may have passed on. These are very, very alarming symptoms and signs, but they're non-specific. They only entail that patient has signs and symptoms of heart failure. They don't define that the cause yet. It's myocarditis here. So we still don't know the cause based on these symptoms. So just remember. But viral pre-syndrome, like fatigue, malaise, fever, lack of appetite, anorexia, etc., and then swelling over the feet, etc., will occur in later stages of heart failure when the right side is involved as well. So having defined the clinical features, having defined what's going on here. Let's go to the diagnostic criteria. So I'm gonna just have to erase this paper, the sheet, and go, let's use the magic pen again to define what the diagnostic criteria be. Now, diagnostic criteria would imply that one, you need to show the clinical features where the suspicion is high. Two, you need to see what the echo is showing. The echo will define clearly the LV dilatation or global dysfunction rather. I'll call it the global dysfunction. And so the EF is down here throughout, and but the LV is not so dilated. That's the thing. LV may not be as dilated, but all you'll see is global dysfunction of all four chambers on an echo. That should lead you. Sometimes you might see LVH because initially the response could be hypertrophy as well. And then there are other criteria where one could see a regional wall motion abnormality also. So regional wall motion abnormalities can exist even on an echo. Now, EKG has not been very specific or sensitive rather, I should say. It'll show some Q waves, it can show some ST changes, and then can also show T inversions, but nothing very specific, and you can see some bundle branches. Of course, that's a very prognostically negative sign. If you see a bundle branch or AV blocks, then those are very ominous signs rather on the EKG. But other than that, they do not really connote anything sensitive or specific. So next would be, in terms of diagnosis, would be the troponin levels. Now, if you were to do the troponin levels, they will be definitely elevated more than 0.1 nanograms per ml, whatever the cutoff is. And that is a good marker suggesting that there is a myocyte necrosis. All troponin level increment really suggests there is myocyte necrosis, nothing else. It does not define what the cause is, but it is a good start here to initiate the diagnosis, specifically with the clinical features, the echo, and the troponin levels. Now, your next test would be based on the nuclear scan, obviously. And nuclear scans, again, we're looking at more non-invasively first. So in the indium, there's an isotope which is indium 111, and that is tagged to the anti-myosin antibody. We call it anti-myosin antibody, and that is tagged, and then it has a predilection to go inside the cells which have myocyte injuries. So as a result, there'll be an attachment of this myocyte antibody, the anti-myosin antibody, to the myocyte proteins, or to the actual protein. And as a result, this indium scan will be positive. So this has a very high sensitivity and sensitivity, as a matter of fact, almost up to the 90% sensitivity. Echo in these findings will also have a fairly good amount of sensitivity, I would say 70% or so, but 90% through the indium scans by the nuclear scans, if you will. Now, if you were to do a regular SPECT scan, for instance, with technetium, that might not show technetium 99. That might show no evidence of coronary reversibility. So, and if you were to do an angiogram, coronary angiogram, there will be normal coronaries here. So it's a normal coronaries here. So in the presence of normal coronaries, where you have an indium scan which is positive, your troponin levels are high, and your clinical features are suggestive that patient has had a fever or a viral prodrome to begin with, and signs of heart failure are being met, and the echo defines that there is a global LV dysfunction, you pretty much have a diagnosis. You don't need a biopsy. But biopsy is the gold standard still. It is very uncommon these days to do a biopsy, specifically because now non-invasively you can really achieve all these diagnoses, but still has 90 to 100% depending upon where, because you could have patchy forms of myocarditis and miss when you actually, again, there are complications involved in the biopsy, specifically the cardiac perforation and death. So therefore it is not popular amongst cardiologists and clinicians to refer patients for cardiac biopsies at all, unless mostly reserved for research and academic centers where prognostic evaluations are being performed. So having said that, let's move on to another page. Let's use the magic pen again here. Hopefully we can, and let's use a different form. Now, once we achieve all of this, you will be surprised that basically the heart will be looking. Now, here's my magic schematic of the heart. So the left ventricle, for instance, will dilate. Left atrium will dilate. Right atrium and right ventricle will dilate after. So you'll have a 4-chamber dilatation of all, therefore it's called the global LV. So the EF will be down. It could be 40% or less, and that's a very, very bad prognosis. If it's less than 40% and patient is markedly symptomatic, make sure you have all the supportive therapy going in. And we'll talk about that in a second. Now, prognostically, there are 3 types of heart failures that you could see. One related to, as we call it, more of the variety which is now fulminant myocarditis, for instance. You have fulminant variety, which is very, very aggressive. The second variety is the giant cell variety, where giant cells can be seen. Again, this is a microscopic diagnosis, remember, so for that you will need a biopsy always. But a fulminant implies that you have progressive heart failure in a very short period of time, less than 2 weeks, preceded with a fever, viral prodrome, and the patient is extremely toxic. Now, that could be, say, the classic example could be diphtheria, where the child is extremely sick right away after the diphtheria because of the diphtheria toxins. So that could be one of the reasons where you could see that getting involved. Now, a lot of other, like a heat stroke or a hypothermia, you could have fulminant type of, because these are sudden, very, very sudden agents that can do that. Anthracyclines, for instance, could have a chronic active type of myocarditis. So again, drug-induced, or we call it chronic active myocarditis. This is predominantly seen in the adults most often. So this is the most often variety, the chronic active variety, myocarditis, and it has a medium prognosis. Fulminant myocarditis surprisingly has the best prognosis, remember, and giant cell is the worst actually. So this is the worst prognosis in the giant cell because not much can be done about it. Just remember that's an autoimmune type of a phenomenon, and unfortunately all immune therapy will have to be placed in as we go along. Now remember, cocaine can also do it, anthracyclines can do it. Amongst the parasites, do not forget the schistosomiasis and of course the Trypanosoma cruzi. The Trypanosoma cruzi is the responsible agent for the Chagas disease as we talked about. Okay, so having said these agents, now the therapy really consists of the following. Well, one, you start with clearly the heart failure management is in place with the afterload reduction. Obviously, you'll start with that, which will include ACE, and it'll include the ARBs, and will include sometimes even IV pressors may have to be used, especially if these patients are very toxic and shocky, if you will. And you end up using all possible diuretics will have to be used. And then you have even intravenous nesirutide has been used in settings where these patients go into acute pulmonary edema. So nesirutide and IV nesirutides have been used in those settings. Having understood the treatment of heart failure, like any other heart failure, after that, of course, the LVAD support, left ventricular assist device supports must be placed in. Intra-aortic balloon pumps may be required. And pacing may be required, especially in a Lyme setting where you may end up with AV blockade. So initially temporary pacing, later on permanent pacing, depending upon if the AV blockade does not disappear and it's taking longer time for the pacing to stay in. So all of these things. And then if the person is hypothermic, then you have to start gradual warming, and somebody is hyperthermic, then you start the patient cooling. So all of that will require intensive care, coronary care unit. So you have a critical care specialist, you have an infectious disease specialist, and of course a cardiologist who is managing this case. So it is a very, very interesting part that I wanted to share in this video for you. So essentially we are looking at various prognoses, but fulminant has the best prognosis, giant cell has the worst, and the chronic active myocarditis they have somewhere in the medium. Now therapy also consists of, let me just use another page quickly and we can wind up here. Essentially, one can also see, besides the supportive therapy we just talked about, which is obviously the heart failure management, one has immunosuppression which is an emerging concept, and people have started using this when supportive therapy fails. And the two drugs are AZT, the azathioprine, and the other one is cyclosporin. These are very immunosuppressive drugs, as we know, and they've been used in renal transplants. Patients, now remember that 1/3 of these patients will actually get better, 1/3 will stay the same slowly, and 1/3 will deteriorate. And the ones who are deteriorating, you need very aggressive therapy, including supportive therapy, immunosuppressive therapy. May also consider these patients for heart transplant, by the way. So the patients where they are not improving at all, because almost in a third of patients, you may end up considering them for heart transplants. Interferons is another area which has been explored, and if everything fails, as they say, then you end up using more guns. So interferons may be the next approach. And IV immunoglobulins obviously have been tried, and they are very successful in abating the immune process, because as we saw, a lot of autoimmune mechanisms exist in myocarditis patients. Immune adsorption is another area. Adsorption, we call it, not absorption, adsorption. And this removes the antibodies from within the body, and that is the concept of immune adsorption therapy. Others are immune modulation, if you will, and there's immune modulation, which is done by actually irradiation with an ultraviolet mechanism. So ultraviolet rays, they can irradiate the autologous blood. The blood is withdrawn, and the mechanism is that you can destroy all the antibodies that are actually involved in the specific myocarditis patient. Hemodynamic support, of course, will have to be provided. So this is part of your regime, and the hemodynamic supportive, which comes in supportive therapy here anyway. Certain vaccinations have been able to eliminate, just so that you know, I do want to mention mumps here. The mumps vaccine is very, very important in the children. That has really eradicated almost the endocardial fibroelastosis type of myocarditis that we used to see. So which is wonderful. So mumps vaccines can even be given to areas where there is proneness for adults and they've not been vaccinated in their childhood. They should be mumps vaccinated as well. So once again, I thank you again to watch MuniMeterHealth.com, your favorite website, which helps you educate you on human heart and its illnesses. It's meant for medical fraternity, as you know, plus also for the general community. And I thank you for your interest. Again, do supplement. I do suggest always that then my videos I suggest that please supplement your knowledge with text, articles, and the textbooks and the current journals. So this way you are more well-versed with managing a case of myocarditis. I thank you again. This is Dr. Sharad Jaitly from New York. Until next video.